Our next speaker is Dr. Mike Caccavale. Mike's been in Santa Rosa for the last 7 years and works as an interventional and diagnostic radiologist for the Redwood Regional Medical Group. I know, it's just Redwood Radiology now. But Mike did his undergraduate training at the University of Arizona. He also went to medical school there, and after a year of transitional internship, he did his residency and fellowship training in interventional radiology at Mayo. So Mike's going to talk to you about maintenance of health with kyphoplasty as his primary topic. Thank you.
Hey, thanks, Mike. Hello all. So today I'm just giving a presentation about vertebral augmentation, how it's used to treat compression fractures, and really hopefully we can talk about why the pendulum's sort of gone back and forth with this treatment for these fractures. So let's go ahead and get started. So first the problem, osteoporosis is very common. So osteoporosis, low bone mass affect greater than 50 million people in the United States. After 50 years of age, the lifetime fracture risk is 1 in 2 for females, 1 in 5 for men. So major sources of morbidity and healthcare costs associated with osteoporosis are related to the fractures. Annually, greater than 60,000 office visits and 70,000 hospital admissions are due to osteoporotic vertebral compression fractures. So this projects by year 2025 there will be greater than 3 million osteoporotic fractures and over $25 billion related to healthcare costs associated with those fractures. And a quarter of those fractures will be associated with vertebral compression fractures. So this is sort of how patients present and the clinical problem that arises when they come into their primary prac or ER, etc. So patients will present with an array of clinical symptoms ranging from minimal to disabling. Patients with minimal pain and functional limitations, or I should say without functional limitations, usually respond well to medical management with resolution of symptoms expected in 6 to 8 weeks. Patients with more severe disabling pain seek medical attention, and that's what we'll actually be talking about today. So what are your options when a patient presents with a compression fracture? Medical management, as we're going to talk about vertebral augmentation, and then open surgery. That open surgery is going to be reserved for patients with unstable fractures or who have neurogenic compromise. So what does medical management consist of? So really it's TLSO bracing, bed rest, and analgesics, most commonly analgesics with narcotic medications. Of those patients that come into the hospital for it, the median length of stay is 10 days, which will be pretty important in a couple slides. So what are the pros of medical management? Well, it's non-invasive. What I want to stress is, although it is non-invasive, it is not risk-free. So cons of medical management. So bed rest, by 1 week, the rate of bone loss is 50 times the normal age-related loss, or rate. After 10 days of bed rest, 15% of aerobic capacity and lower extremity strength is lost, equivalent to 10 years of age-related loss. And again, remember, the average length of stay is 10 days for hospitalized patients. So there's also increased risk of DVT, pneumonia, and respiratory failure. So all that will equal an increased mortality for these patients. Narcotics. So we all know of the adverse effects, sedation, nausea, constipation. When you think of sedation, you should also think that's going to increase the time that they're going to be on bed rest, increase their physical deconditioning, and then also increase the risk of fall in these patients who have osteoporosis and obviously are increased risk of fracture. So risk of fracture itself in compression fracture, really there's a risk of fracture progression. Commonly that's just associated with malalignment, decreased height. Rarely you can actually have progression of the fracture to where it actually compromises the spinal canal, leads to neurogenic compromise, and requires surgical fixation. So post-hospitalization for medical management, about 50% require ongoing care. Chronic pain will be present in 40% of these patients, and actually 1 in 5 of these patients will be readmitted to the hospital within 30 days. So then we'll talk about vertebral augmentation, what it is, what are the types, how we do it. So in this slide, this is actually a kyphoplasty procedure. And you can see where it says basically cannula. Those are hollow needles. So in essence, you're able to put a needle in with the stylet, it goes in, you pull out that middle stylet, now you got a hollow channel where you can put in tools or the cement that you need. And this is showing the balloons that go up in a kyphoplasty procedure. And those are used to actually create a cavity as well as increase the height or alignment of what that vertebral body used to be. And then this is actually the cement that's filled in after those balloons are deflated and pulled out. So what is augmentation procedure? Well, it's a minimally invasive procedure in which cement is designed for use. Polymethyl methacrylate is injected into the vertebral body. So there's two forms really, vertebroplasty and kyphoplasty. So here's kyphoplasty, and like we said, there's the fracture where you can see there's a compression, a wedge deformity. You insert those cannulas into the vertebral body, usually through the pedicles, and then you use the balloon, as we talked about, to restore height as well as create a cavity, and then you fill that with cement. Different from a vertebroplasty, which is you just put the cannulas into the vertebral body and you fill that with cement. There is no balloon augmentation in that procedure. So is one better than the other? Not necessarily in terms of clinical outcome or risk. So there's limited data to compare. There's no difference in clinical outcome as we talked about or symptomatic complications. There is evidence that does demonstrate benefit of kyphoplasty with lower rate of cement leakage and greater alignment. So in essence, when you take that balloon up and you create that cavity, that's going to give you more space to fill it in with cement. And that balloon can actually then, by inflating it, restore some height of that vertebral body. So that's the point of doing kyphoplasty over vertebroplasty if you decide that was the way to go. And really, that's just the same slide showing what we talked about. And if you actually look at the wedge in that vertebral body compared to now what it looks like post, you can see that they had some decent restoration of height and better alignment for that patient. So what are the safety concerns? So really this is a low-risk procedure. Less than 1% risk of major complication, which most commonly we talk about bleeding, pulmonary emboli with cement going into the venous plexus surrounding the spine, and then neurologic deficit, which would be if that cement actually came into the canal, affixed the cord, or rarely go into the foramen and affixed those nerves that are coming out. So talked about that cement leakage outside the vertebral body is very common actually in the procedure as one of the points where you start to slow down and stop injecting the cement. It's very rarely symptomatic, and it is less likely, as we talked about, in kyphoplasty because you're creating that cavity. So augmentation does not increase the baseline risk of new compression fractures with similar subsequent risk of compression fractures observed in medical management patients. Because remember, we're not treating the underlying cause. They have osteoporosis. What we're doing is we're treating their symptoms of pain and disability. But these patients are going to have osteoporosis afterwards with medical management or augmentation. So both treatments aim to reduce pain, morbidity, mortality, as well as improve alignment. Treatment success was documented on many early observational studies. So then we come in, so why the controversy? Why do you see this pendulum swinging back and forth with referring these patients in for any procedure? So concerns develop after these observational trials. There was a lack of randomized control trials, improvement in back pain for some, regression of the mean for others, and a question of the placebo effect. So some early RCTs evaluating vertebral augmentation demonstrated no clinical benefit compared to medical management. And really I'm going to talk about the main 4 studies that have been performed, which is, like I said, sort of swung that pendulum back and forth. So early trials are particularly susceptible to bias and placebo effect. Sham trials were then performed, and all 4 of the trials we're going to talk about had a sham procedure performed, and that was to minimize the placebo effect. However, the earlier sham trials included patients with acute, subacute, and chronic fractures. And that's one of the things that's going to make a big difference in the patients selected for the procedure. So the more recent trials have rigorous patient selection. So these patients have severe pain. So they have pain of 7 or greater, treated with acute. So the way they actually talk about acute, subacute, and chronic fractures is 0 to 6 weeks is considered acute, 6 to 12 subacute, and 12 on chronic. So these studies treat more of the acute to subacute, and in this vapor trial that we're going to talk about, they were all acute fractures. So there's also a MR imaging or any kind of advanced imaging that shows edema within that vertebral body that's to be treated, most commonly MR, but you can also have a bone scan for patients who have some contraindication to MRI that can help, or any recent CT can also be used to go ahead and go on for treatment. So these more recent trials, the one we're going to talk about, certainly demonstrate a clear benefit with decreased pain scores and median length of hospital admission. There was 5.5, and remember we talked about the other one was 10 without a procedure, and hospitalized patients. So additionally, anatomic outcomes are superior with 30% greater vertebral height preservation, and as we talked about in kyphoplasty, you actually get not only preservation, but you can actually regain some of that vertebral height and reduce patient mortality compared to medical management, which makes sense. Maybe they're reducing the hospitalization of the patient. So busy slide, but here are the first three that they always talked about where people were saying, well, there's no longer any reason to treat these patients with any vertebral augmentation. And we can see that trials of Buckbinder and Invest, those were the two trials that basically show there's no clinical benefit. And this Vapor trial, this more recent trial, there's a little more rigorous with their patient selection. That's the one that actually showed benefit. So what I want to stress is what's in red there. And you can see in the Buckbinder and Invest trials compared to the Vapor is that pain scores, they didn't have any qualifications. So you could have a 1 out of 10 and they were treating patients. In Invest it was greater or equal to 3, and then the Vapor was greater or equal to 7. So obviously these patients weren't severe. You could say these were mild and these were minimal to anything. So then you go on to how old is the fracture? We talked about it's going to be very important. So Vapor trial is acute. It's less than 6. Invest is less than 52 weeks. And same with the Buckbinder. So that's going to make a significant difference in the patients that we want to see for these procedures. And you can see that really of their fractures, they were going more acute, subacute, 40%, 20%, and then in the Vapor trial, that's 100%. So was advanced imaging used? It was used actually in the Buckbinder. It wasn't used in the Invest trial, and it is used in the Vapor trial. Other things that people talk about, which is of questionable significance really, is how much cement that people are using. 2.8 mLs is in the Buckbinder. They didn't actually record that in the Invest, and they were pretty aggressive in the Vapor trial and actually filled it with 7.5 mLs on average of cement. So as we talked about, the first two trials, no difference from medical management in terms of really pain outcome in medical management or vertebroplasty. And then in the Vapor trial, they showed that there was a much better result with vertebroplasty. So given that trial that came out, there was earlier from the first two trials, a lot of the groups and associations were recommending against sending people for kyphoplasty or vertebroplasty, any kind of augmentation. But you can see after this later trial came out, there are many groups, including, and we can talk about a little bit, the American Academy of Family Physicians, radiology, neurologic surgeons who consider augmentation as a valid treatment option for patients with ongoing pain or disability, basically who have failed medical management. So I'm not going to make it that easy. So here comes a trial that came out that's a newer, there was a randomized control trial. This is 2018. Everyone's sort of waiting for this trial to see what the results would be and should we continue to proceed with doing augmentation. And this was called the Vertos 4 trial. And this actually came back to showing what the first two trials showed. So then everyone took a pause and everything came out of the news saying, again, maybe we shouldn't be doing this. Maybe all these patients should be on medical management. So real quickly to go over this, we don't have to go too much into this, but in essence, they had 180 patients. The average fracture time was about 6 weeks. And let me go to the next slide so it's not so small. So why the difference? And I'll show you. They are very different trials, the Vapor and Vertos 4. So this is the biggest things. The treatment timing, one is 2.8 weeks, the other is 6.1 weeks. And again, pain. They were treating patients with only, greater than 4 out of 10 pain. And again, these were treating much more severe pain. So 90% of these patients had severe pain. Only 34% in the Vertos trial had pain greater than 4. Hospitalized patients, yes. All these patients were able to be managed outpatient. So significantly different patient population. That explains the difference in results. That's why people still recommend going on for an option for augmentation. So what does this all mean? Rigorous patient selection is hugely important for success. Optimal patients with severe pain, so that pain score greater than 7 out of 10. I think it's easier to think of it as if you see a patient that comes in and they're requiring narcotics and it's an acute, subacute fracture, well then that's a reason to go for an option for actually having an augmentation. So less than 6 weeks of fracture onset, and then imaging correlating edema with fracture and symptoms. So realistic expectations, certainly it is not a magic bullet, but properly selected patients have a good chance of significant pain relief, decreased narcotic necessity, decreased bed rest with early return to normal life activity, improved mortality, and improved alignment. Questions? We do. That actually we do with ablation. So that's do I have any, is there any data out for malignant fractures? So pathologic fractures relating to metastatic disease, most commonly multiple myeloma you could also have. So there is, and that's more actually with a lot of people doing RF and you're filling it in with cement afterwards. There's actually very good data to show that you get great pain relief when you have a synergistic effect with radiation treatment along with an ablation followed with cement injection. We do, yeah.
Is an X-ray significant imaging?
No. Well, I mean, X-ray does show you that there's a fracture, but you need either an MRI or a SPECT. So usually if someone comes in, let's say they come into your practice, you get a spine X-ray and they have pain associated with where's the compression on a fracture, I would say that's the time where they should be sent for a consult. And then what you like to do is have them get a MRI very soon after the consult. We like to get them basically stats so that we can schedule everything out within 1 week because you want that MRI to be available within 1 week. So we talked about fracture progression. If they're too far apart, you're actually, you can see changes when you go to do the treatment compared to the MRI that you just got. Yes?
To refer somebody to interventional radiology?
Yep.
Do you know how kyphoplasty works?
So we see these patients early. So we don't actually, we'll fit in a kyphoplasty or a vertebroplasty because of the reasons where you saw where acuity is a big difference in patient outcome. So there is no wait in essence. We like to see them and get them treated within a week.
Was there any age variation in these trials?
There's a lot of age variation. I could go back to one of the things you can see there. I didn't put it in red, that's why you didn't. But in this you can see, I know this is a busy slide actually, wish you would have projected a little better. But mean age in this is 76. 76% of them were the females. And that was in the one we talked about the vector. And then this one, age. Inclusion thresholds, it was none in that bookbinder. It was 50 in the INVEST, and then it was 60 in the VAPOR trial. So these are all, we're talking about osteoporosis. So these are all going to be more age patients. We do treat people at any age. It's more rare that we see young people. We've treated people with traumatic fractures who have failed medical management before.
Is there a minimum compression angle you'd recommend before you consider this procedure?
No, I mean, it does depend on how the image looks on MRI, but we don't go by a specific angle per se. So if we think that there's enough bone stock, you know, if you have like an elderly female, that angle is going to be, the same angle is going to have much difference in someone who is a larger male and they have more bone stock. So you're not going to have as significant of an actual sandwich vertebral body, even with the angle the same. So we don't go by angle, we actually just go by the way that actually vertebral body looks. And for the most part, if we think we can get the balloon up and restore some height in it, we'll go ahead and treat.
You mentioned earlier when people cannot get an MRI, you recommend a CT?
We can get a CT and you can also do a bone scan with them.
Which one is the preferred?
It depends on the patient and how well we think they're going to tolerate one of the other procedures.
And also, does the procedure increase the risk of adjacent vertebral fracture?
It doesn't. You do see a lot of fractures that happen above and below, but those fractures, when they compare them, depending on the study that you read to medical management, they still have they have the same time coming back with another compression fracture. So again, what we're treating is the fracture itself. We're not certainly making the bone stock to the vertebral bodies better that are around them. But their chance of having a fracture, regardless of kyphoplasty or augmentation, compared to medical management, is similar.
Is there some percentage of compression that triggers an automatic you would really recommend the procedure when you're following them?
No, it's symptoms, for sure. So if they, like I said, it's not the amount, because we treat, you'll see symptoms vary even with small, not really, you're saying high angle compression fractures. It is just the point that vertebral body is fractured, and the theory is you have basically these unfused bone, and they have micro motions around them, and that's causing a lot of inflammation and pain. And so if that has enough pain where they come in and they need medical management of narcotics, then I would say we'd bring them in and evaluate them, but not necessarily just based on the way that vertebral body looks, as much as their symptoms around it.
Do you do this in cervical vertebrae?
We don't. We don't here. I would imagine a neuro-IR maybe a little more apt to do that, but usually you're not going to have a compression fracture that high up. It certainly can happen.
How many vertebrae you can do in different times?
So we usually do about, the max we do is 3 levels.
Could you talk about the ways in which the vertebroplasty was superior in the vapor trial? Like what were the numbers or the outcomes that?
Sure. So in essence, let's see what I got on here for you actually to show. What they were really trying in the vapor trial was reducing pain and then hospital stay, et cetera. So the vapor trial basically had it to where they had 30%, like I said, stabilization of height at least, or then they had a decrease in pain. So putting patients below 4 was their level, and that was significantly higher than doing medical management that lasted, to at least 6 months was theirs. And then the other thing they talked about was hospital admission stay, which was 5.5 days. So in essence, they showed a significant difference in pain, hospital stay, as well as stabilization of fracture. That answer your question?
If someone needed to have a procedure and they're someone who has other spine disease, would having this preclude them from having other spinal procedures?
No. It would, no. Because sometimes you have to go in actually, rarely if you got cement in the wrong place, they go in and they actually do have to do a spine procedure at that time. But are you wondering, can they drill through that cement if they needed to do a fusion? I would have to talk to a neurosurgeon, but I've never been told that's an issue. When I talk to them about doing it, would this preclude you from doing it? And they say, no, go ahead. So Jacques may have a difference in opinion in that, but he's never told me any different. Yeah.
One last question.
Okay, I've got it.
We do.
I keep trying.
Do you do thoracic spine?
Thank you very much, Mike.
Is that-
I'll talk to you later. I'll answer.
Hi, so if you're doing this on a patient with osteoporosis and this patient starts something like Forteo or Timlos, how will that change the environment around which you've placed the cement, or will it?
It won't. It won't. What we're trying to do with the cement is actually get it enough filling in that vertebral body to support it, and hopefully we actually will get it nice and in the fracture plane, so it will, like I said, stabilize that fracture site and give the patient less symptoms.
Thank you very much.
Okay, thank you.